You are welcome to my channel. Thanks for visiting. If you haven't subscribed, please kindly remember to do that. But if you are subscribed and you are visiting again, I'm saying a big thank you. Today, I'll continue on infective endocarditis, focusing on preventive measures and possible prophylaxis. If you haven't listened to the first presentation, please kindly do. I have published the definition of terms and brief anatomy when it comes to infective endocarditis, including the risk factors already published. So without further ado, let's go through prevention and prophylaxis when it's all about infective endocarditis. Certain preventive measures will have to be embarked upon once the risk could be identified in an individual. Let's start with dental procedures. Not only the surgery with dentists, even in daily lifestyle, you have to be careful. Make sure the teeth or the mouth generally is kept clean. So improve upon oral hygiene. Then don't poke that gum often. From normal toothbrushing, poking the gum all the time is not healthy for anyone with high risk of infective endocarditis. Also, the use of toothpicks. Now, the list is right there, already published. Check my channel for the risk factors for infective endocarditis. IV drug use. You know what? Don't let us waste time. Just stop it. Stop it. Aseptic procedures. Yes, the gadget to be used must be devoid of germs, bacteria, or fungi. Then select wisely for prophylaxis. Yes, we'll go through that right here, so I will not waste your time right now. Then we will embark on thorough history, physical examination, checking for peripheral stigmata of infective endocarditis, and then embark on correct treatment. When we do all this, do you know what's going to happen in the center here? There will be decreased morbidity and mortality due to infective endocarditis. We will go through prophylaxis today, but let me branch and tell you right now that there are a lot of controversies over prophylaxis here. To those who are for prophylaxis, they are saying if you give antibiotics before dental surgery, respiratory procedures, soft skin, and all those things, you are likely going to save that life, prevent more morbidity and mortality. Okay? Those who are against, they don't even believe in the prophylaxis. And they have their reasons. Some claim that not more than 10% of infective endocarditis cases will actually be prevented. But at least we are going to get the percentage, right? Though they said not more than 10%. No, that's fine. Some believe that the bacteria agent will not be susceptible to the known agent we may use for prophylaxis. And that is reasonable, okay? And some say that the efficacy of the antibiotics has not been so established. Well, later on, with all those reasonable and good points against prophylaxis, reality now setting. Some stopped prophylaxis. Guess what? They saw increase in cases of infective endocarditis, although not so geometric, not a geometric fashion, but at least slight increase. Whatever the choice, whether you are for or against, remember those who stopped some time ago, and then something will happen at the center. What would that be? Some people will likely pay for our choice. So let's put the controversy somewhere. Let's go ahead with prophylaxis. Now, let's go through the list of those that will need this prophylaxis badly. And that will be those with known high risk factors. So those with known high risk factors will include anyone with past history of infective endocarditis, anyone with heart transplantation, anyone with coronary artery bypass graft, known congenital heart defect that is not yet repaired, like patent ductus arteriosus or ventricular septal defect, anyone with prosthetic valves, or anyone who had the congenital heart disease fixed in the last 6 months will have him or herself on the list of high risk individuals. There are some other associated risk factors, but not on the list of high risk, as anyone on chronic hemodialysis, a known case of hypertrophic cardiomyopathy, IV drug users, HIV, and so on. So, once again, check my channel for the associated risk factors with infective endocarditis. So, to avoid any controversy that we've gone through before now, let's get down to who really needs prophylaxis. Because we're not going to give every patient that comes to the clinic or will undergo surgery the prophylactic agent, right? No, high-risk individuals going for the following procedures will need prophylaxis. But before giving you the list of the procedures, then let me visit the patho that we need to know here. Yeah, when the individual goes for such a procedure and the germs, bacteria this time or fungi, should get into the blood, that is bacteremia, and such reaches the abnormal endocardium with dysfunctional endothelium, then the germs will be trapped. When trapped, the bacteria or fungi will reproduce. They will proliferate, they will grow more, and they will do that tremendously. Then vegetations will be formed on the endothelial surface. And remember, that could be on the valve or anywhere lining the cavity of the heart. Now, let's go through the list of the procedures when and where we will need prophylaxis. Attention is on dental procedures, but that is not the end of all the procedures that will require prophylaxis against infective endocarditis in high-risk individuals. So, dental procedures, bone marrow transplantation, even blood transfusion, transesophageal echo. It's not all the time we need this. It depends on the setting, right? Percutaneous coronary intervention, bronchoscopy, skin or soft tissue procedures, genitourinary procedures, even gastrointestinal tract procedures, even with OBGYN, cesarean section, and vaginal delivery. In a nutshell, any procedure that can allow blood to be probably contaminated and then allow the bacteria to get into the circulatory system will eventually lead to infective endocarditis in high-risk individuals. Such procedures should have prophylaxis against infective endocarditis. Now, we've made up our mind that, okay, this is a candidate for prophylaxis, right? What agent can we use? We can start thinking about per agents. If there's no allergy against penicillin and the individual could take per, the first choice will be amoxicillin. I will not be giving you the dosage, but for the first time, I will do that with amoxicillin. If it's an adult, you can give 2 grams of amoxicillin per oral, and that should be given between 30 minutes to 60 minutes before the procedure. If it's a child, you can weigh and give 50 milligrams per kilogram per hour. The individual is capable of taking per oral agent, but there is positive history of penicillin allergy without anaphylaxis and angioedema. If that is the case, we can use cevalexin. The individual could take per oral, but there is positive history of penicillin allergy with anaphylaxis or angioedema. It means it's serious. So we will not take the risk of giving cephalosporins here. Remember the previous slide, I said without anaphylaxis or angioedema. So we could give cephalosporin. But when the history is involving anaphylaxis and angioedema, against penicillin, then we should not take the risk of giving cephalosporins. So we can go for azithromycin or clarithromycin, doxycycline or vancomycin, depending on whether we have methicillin-resistant Staphylococcus aureus or vancomycin-resistant Staphylococcus aureus around. Now, the individual cannot take per oral agents either because he or she is vomiting or too toxic to take per oral, or there is the other rating nil per oral. If that is the case, we'll go for parenteral route, intramuscular or intravenous agent. If there is no history of penicillin allergy, we can then give ampicillin, cefazolin, or ceftriaxone. The same, that is, the individual is vomiting or toxic or need per oral, so cannot take per oral agents, and we are going for what we can give intramuscularly or intravenously, that is parenteral route, right? But if there is positive history of penicillin allergy without anaphylaxis or angioedema, we can go for cephalosporins like cefazolin or ceftriaxone. Still not able to take per oral because he or she is vomiting, toxic, or the other is need per oral, and we are going for a parenteral agent. If the allergy to penicillin history is right there with anaphylaxis or angioedema, then we can go for vancomycin. We will not use cephalosporin here. Finally, our goal is to prevent morbidity and mortality due to infective endocarditis. We've gone through the list of agents we can use. Take your own decision with or without the help of the expert or experts in your jurisdiction. But we just have to help that man or woman and prevent morbidity and mortality. With that, I've come to the end of this short presentation as per infective endocarditis, prevention and prophylaxis. Thanks for listening. Please share this with your friends on your platform. I appreciate it.